Medical misinformation is everywhere. Dr. Mitch is here for straight talk and to give you the truth.
Blood electrolytes are critical to patient care. It gives you insights to the physiological balance when you're guiding treatment decisions. We're going to explore that today. Sodium, potassium, chloride, bicarbonate, calcium, and magnesium, and what it might mean for you and your patients. It'll be a good primer just to catch up. Electrolytes are charged minerals. They regulate nerve function, muscle contraction, fluid balance, and acid-base balance as well. Imbalances signal acute or chronic conditions from dehydration to basically organ dysfunction. Now, let me break down each of the electrolytes and what it might clinically implicate. First, sodium with a normal range of 135 to 145 millimoles per liter. It controls fluid balance and nerve signaling. Hyponatremia may indicate overhydration, heart failure, or SIADH. They can include symptoms of confusion, seizures, coma. Opposite end, high sodium, stems from dehydration or diabetes insipidus, thirsty, lethargic, and again, it could have renal types of consequence. You need to check these things because you can get cerebral edema for when these are not, sodium is not in check. Now, potassium ranges from 3.5 to 5 millimoles per liter, is vital for cardiac and muscle function, and hypokalemia, low potassium, can result from diuretics, vomitings, alkalosis, muscle weakness, dysrhythmias, or paralysis. High potassium, or in renal failure, acidosis, or in ACE inhibitor use. It could cause a bradycardia and cardiac arrest, for sure. EKG monitoring is critical for potassium imbalances, as changes like peaked up T waves or widened QRS complexes can signal urgent intervention. And adjust medications and diet carefully, especially in chronic kidney disease patients. Now, chloride is typically 98 to 106 millimoles per liter. It works with sodium to maintain fluid and acid-base balance. Hypochloremia recurs with prolonged vomiting or metabolic alkalosis, where hyper often accompanies dehydration or hyperkalemic acidosis. Chlorine, by the way, shifts are often follow sodium. So interpret these things in context with each other and monitor inpatients that are on TPN with acid-base disorders. Now, bicarbonate, it ranges from 22 to 28 millimoles per liter. It's the primary buffer for the blood. And low levels suggest metabolic acidosis, as in DKA or renal failure. High indicate metabolic acidosis in vomiting or diuretic overuse. Blood gas analysis sometimes has to be used to monitor these trends. Now, calcium has a total serum range of 8.5 to 10.2 milligrams per deciliter. It supports bone health, muscle contraction, and even clotting. Hypocalcemia is linked to low parathyroid, vitamin D deficiencies, and can cause tetany and seizures. Hypercalcemia, on the other hand, is hyperparathyroidism or even malignancy. It leads to fatigue, kidney stones, or dysrhythmias. Now, ionized calcium is more accurate in critically ill patients, as albumin levels affect the total calcium readings. That's why always do a recalculated calcium. Calcium minus the albumin plus the constant of 4 will tell you if it's in the normal range or not. Finally, magnesium of 1.7 to 2.2 milligrams per deciliter aids enzyme function and neuromuscular stability. Hypomagnesia is common in alcoholism or malabsorption cases and can cause tremors or dysrhythmia. High magnesium is often seen and can cause low blood pressure, respiratory depression, and is seen in renal failure as well. Check the magnesium levels, but more importantly, you should be checking the red blood cell magnesium levels, as we've talked about in previous presentations. Monitoring electrolytes requires a systemic approach. Order comprehensive metabolic panels for at-risk patients, those with renal disease, heart failure, acute illnesses. And of course, if they're in an ICU, you may need to get them daily. If you're doing or using intravenous nutrition in your offices like I do, please, every fifth IV, monitor at least the complete metabolic profile with electrolytes and even a CBC in certain instances. So what do imbalances mean for patients? Electrolyte abnormalities can be diagnostic clues or treatment complications. Low sodium is confused in elderly and may suggest SIADH, while high potassium in a dialysis patient may mean inadequate clearance. Trends mean more than just a single. You need to look at outcomes, look at the electrolytes together, and measure your treatment accordingly. And always double check for pseudo-hypercalcemia or pseudo-hypokalemia, which can occur if the tourniquet's too tight in the way it's drawn or if it's left out and not spun down. Again, we've talked about this before. In summary, electrolytes are the window to a patient's health. Monitor them, watch them. They will prevent complications, improve outcomes. Again, if you're doing IV therapy and you're prescribing different nutrients for your patients, please monitor this often. It will help you make sure that you keep your patients safe. Thanks so much for watching.